Hello and welcome to the Best of the Day at ESMO 2014 in Madrid. My name is Axel Grothy. I'm a medical oncologist at Mayo Clinic in Rochester, Minnesota. Here with me is Florian Lorik, a good friend of mine from Germany, who is a specialist in GI malignancies, and we'll talk about the very broad spectrum of GI cancers and some of the abstracts which were presented here. Welcome, Florian.
Hi, Axel.
So let's move from, let's say, pancreas cancer to gastric cancer to colorectal cancer, because I think these were the most important areas that were covered here at ESMO. Pancreas cancer, I mean, 3 years ago we used gemcitabine single agent. Now we have more complex and more effective treatment regimens. And one of the standards of care that had evolved, from the French pivotal study was FOLFIRINOX. So here at ESMO we saw a confirmatory trial.
Absolutely. It's an amazing story, isn't it? Because in other tumor entities, we are really going more into tumor biology and into targeted treatments, trying to make some progress. But for pancreatic cancer, it's a little bit different because classical cytotoxic combinations have brought the field forward. And this is especially true for FOLFIRINOX. We had the New England Journal paper from the French group a couple of years ago. And now on this Congress, they presented a randomized study which was done in India. This is also an interesting thing that now we have more clinical research also from other areas of the world. And they could exactly confirm the difference in terms of median survival when they compared treatment with gemcitabine to treatment with FOLFIRINOX. And I think it's good to know that also other groups see this gain in survival. They also have, of course, some feasibility data, toxicity data, which are really in line with what we know from the French study.
I mean, FOLFIRINOX, at least in my hands, has really changed the way I treat pancreas cancer. We see more. It's an interesting, I think we made a mistake in pancreas cancer. For a long time we thought aggressive cancer, let's give gemcitabine single agent because we don't want to harm patients. Aggressive cancers need more active treatment, I think, right up front. We have FOLFIRINOX now. We have another combination therapy, gemcitabine, nab-paclitaxel. Yeah. So what are the data on nab-paclitaxel?
Yeah, you're referring to the data of the IMPACT study, which combined nab-paclitaxel, which is a new formulation, a new way to deliver paclitaxel to the body and to the tumor, which is associated with a comparable survival gain if you take the data gemcitabine compared to FOLFIRINOX, and if you compare it to the study comparing gemcitabine versus gemcitabine and nab-paclitaxel, it's about in the same range. So you're completely right that now we have two more active, aggressive treatments, but which really make a difference for the patient.
The word aggressive doesn't sound right because we want to be more active, and but it's more. We have more side effects.
We have more side effects, and I don't know how you're doing it in your country, but we are still selecting patients. I mean, if there is a patient with some comorbidities or also in the elderly population, we are more cautious with the new combinations. We still tend to give gemcitabine sometimes combined with erlotinib, but for the younger ones and the one who can tolerate a combination chemotherapy, we are really going for FOLFIRINOX and also gemcitabine paclitaxel.
I think we are looking at the data in very much the same way.
Yeah.
So gastric cancer is another cancer with a high unmet need, where we see kind of an evolution of, probably not besides HER2, not a very biomarker selected treatment option. I don't know what kind of standard of care you use in first-line therapy. There's a variety of different treatment options right now.
Yeah, there's a variety of treatment options, but overall we are using a platinum 5-FU combination in Germany. We sometimes add docetaxel, which has shown to improve outcome, response rate is better, overall survival is better, but we clearly add some toxicity. So we also restrict this to patients in younger age and who can tolerate a triplet combination in first line. And you're exactly right that we do not have so many targeted treatments yet, but I think gastric cancer is really an interesting field because now we have more insights into biology. There's a very recent paper from the Human Cancer Genome Projects where we get insight into molecular subtypes of gastric cancer. So probably things will come.
Yeah.
And one promising thing that has been shown here at the ESMO Congress is immunotherapy, which is directed against the interaction of PD-1 and PD-L1. And there are antibodies now. There is new data now from one antibody, which is called pembrolizumab, which is directed against PD-L1. And they presented first results of a phase 1b, phase 2 study where they saw 30% response rate, which is unusual in a heavily pretreated patient population. And maybe certainly we will have to learn more about this new story, because they restricted that to a subpopulation of gastric cancer who were positive in immunostaining for PD-L1 expression. And certainly we have to learn more about this biomarker and how to select the patients for this treatment. But it's a good new signal.
Yeah. I think after the very interesting data, melanoma and non-small cell lung cancer, every field, every subgroup of tumor wants to have some positive result in immunotherapy. And I like the gastric cancer data, were quite interesting, and I can see this is moving forward at some point. Yeah. So another area where, you know, we had kind of a hit and miss strategy in gastric cancer was anti-angiogenesis. So there's this old study, the AVAGA study, where bevacizumab did not show to be efficacious, at least not in the overall patient population. And then ramucirumab came around and had two positive trials.
It's an interesting story, isn't it? Because we have the AVAGA study, which was done in first-line treatment of patients with metastatic gastric cancer. And this was basically a negative study. There were some trends in favor of anti-angiogenic treatment, especially in the non-Asian population, but overall survival was not significantly improved. And now we have two positive studies in the second-line treatment of gastric cancer. We can use ramucirumab as a monotherapy, and it is better than delivering best supportive care alone. But we can also combine it with weekly paclitaxel, which is a quite well-tolerable treatment.
And a standard treatment.
And a standard treatment. It's a standard second-line treatment also in our country. And by doing this, we are achieving a response rate of 30%, which is interesting for second-line in gastric cancer, and we are prolonging survival. So it is really interesting that obviously gastric cancer is a disease that can be treated with anti-angiogenic compounds, maybe not so much in first line, more in second line. We do not have positive first line data yet. It will be interesting to see if something will be coming in the future, but we can say for sure that anti-angiogenic treatment should be delivered to a majority of patients who are treated for metastatic gastric cancer. It adds something, prolongs survival, it stabilizes.
It was pretty well tolerated too.
It's pretty well tolerated, especially the monotherapy has basically no subjective side effects. You need to watch out for hypertension and all these things that are in association with anti-angiogenic treatment. In combination with paclitaxel, you still have the taxane-associated side effects, a little bit augmented by the addition of ramucirumab, but not dramatically. So I would say in our hands we now have a well-tolerable treatment which is of benefit for our patients.
So ramucirumab as a VEGF receptor 2 antibody has now recently had a press release having positive data in second-line colon cancer. We haven't seen the data yet.
We haven't seen the data yet.
It's going to be presented at some of the future meetings. Now, that brings me to colorectal cancer as the largest, kind of more important, most important cancer in the GI tract. We saw some data here at ESMO about maintenance therapy, adjuvant therapy, and actually a big discussion is coming up about the head-to-head comparison between cetuximab and bevacizumab in two different trials, one in Germany, and a German trial, and one in the US. But first, let's talk about maintenance therapy. A German trial was presented, a phase 3 study. What are the key points on this study?
Well, the key points on this study is that maybe we have something like a standard of care now, which is doing some kind of maintenance therapy after a period of induction therapy. Basically, for me, the thing is that patients with colorectal cancer have a realistic chance to live with this cancer and with this tumor stage for a long period of time. And it's important to find a strategy not to treat them too aggressively, too intensively. And therefore, a variety of studies has focused on the point, can we decrease the intensity of treatment? Can we make intermittent treatment? What intensity is needed not to deteriorate the outcome? And the German study has shown or confirmed that a combination of fluoropyrimidine and bevacizumab can be regarded as a standard, but maybe bevacizumab alone can also maintain the same outcomes. It's maybe not necessary to deliver 5-FU of fluoropyrimidines in addition to bevacizumab, but this is certainly not the only option. I mean, we have also data from the Netherlands. The Dutch investigators, they combined capecitabine, another fluoropyrimidine, and bevacizumab. There is also some interesting data from France, the DREAM study. They combined bevacizumab and erlotinib, which is not a typical compound that we are using in our daily life, but they showed that this combination also has an effect on progression-free survival and even on survival. We even have interesting data from Spain, who combined FOLFOX with cetuximab in RAS non-mutant patients and went on with a cetuximab maintenance therapy and achieved comparable outcomes compared to the FOLFOX and cetuximab combination. So this just shows the variety of options we have. It looks to me that doing anything is better than nothing.
Yeah.
But of course, this is all still for me a very individual decision that we have to take together with the patient.
I think it's a very key point.
Yeah.
If we want to delay tumor progression, something's better than nothing, and we are almost forced into some induction maintenance strategy if you use an oxaliplatin-based first-line therapy, which a lot of people use around the world, especially in the United States, where penetration is over 70%. So the cumulative neurotoxicity needs to be really strategically prevented by limiting the duration of oxaliplatin exposure, and then using some form of maintenance therapy, or in select patients even giving a complete break, because not every patient needs maintenance therapy, even though the ESMO guidelines say it's the preferred way of doing it, and I would agree with that. Now, the form of maintenance therapy, as you said, fluoropyrimidine plus bevacizumab, an antibody alone, or I think for me, surprising data of erlotinib, bevacizumab, which I think we need confirmation, you know.
That is really surprising, even more as it was regardless of the RAS type of mutation, etc. There is still a lot of biology in this kind of maintenance treatment that we do not understand yet. And I personally would say, at least for my country, probably it's the same for the US. This is not an available regimen because we do not have approval for erlotinib in the treatment of colorectal cancer.
Yeah, I think it's, you know, erlotinib has not shown to be efficacious in colorectal cancer as a single agent, in contrast to fluoropyrimidines, you know. And so I would say before I use an erlotinib bevacizumab combination, I would like to see data comparing this double biologic treatment against fluoropyrimidine bevacizumab, which has emerged more or less, as you said, you know, from various trials as one of these standard therapies that we can consider. Now, closing off with bevacizumab, before we, in the one session that was presented at ESMO, before we move on to the head-to-head comparison, there was an adjuvant trial, the QUASAR-2 study, another adjuvant bevacizumab study.
Yeah,
anything surprising?
It's a sad story because we have learned that bevacizumab does not work in the adjuvant setting. And so this is confirming the negative results that we earlier had from the North American trial, but also from the AVANT trial. But it's a clear result.
Clear result. So QUASAR-2, capecitabine plus minus bevacizumab, it's adjuvant therapy. Again, negative data, now validated by a UK study. Now, the hot topic in the last 12 months was probably head-to-head comparison between EGF receptor antibody versus bevacizumab in first-line therapy added to chemotherapy. We know that we should not combine these antibodies.
Yeah, that's,
you know,
that's clear on the basis of the previous studies. Cairo and PACE trial showed that a combination of both antibodies just does not work in the metastatic setting.
So we need to use one or the other first. So that's the rationale of doing the head-to-head comparisons. We actually have a session today putting these two somewhat conflicting trials head-to-head, the FIRE-3 study and the CLGB SWOG 84-5 study. What was FIRE-3?
Well, FIRE-3 was a comparison of FOLFIRI, irinotecan, and 5-FU, which is kind of our preferred first-line chemotherapy backbone in Germany. And this was either combined with bevacizumab in the one arm or with cetuximab in the other arm. And the primary analysis was based on KRAS wild-type status, but with the exon 2, But with the time when we learned more about molecular testing, also the other exons of the KRAS gene were analyzed and the NRAS gene was analyzed. So we now have data for whole RAS wild-type, for the whole RAS wild-type population. And it's interesting results from the FIRE-3 study because we do not see any difference in terms of progression-free survival, but at the end of the day we are seeing a major difference in terms of overall survival. The difference is 8 months. It's 25 months in the FOLFIRI plus bevacizumab arm and 33 months overall survival median in the FOLFIRI plus cetuximab arm. So this makes a difference.
It has a ratio of 0.7. Primary endpoint of the study was investigator-assessed response rate, which was presented last year, which was negative.
It was negative, but meanwhile the group has presented some independent review of the data, which is interesting because now they are seeing a difference. And they are seeing earlier shrinkage of the tumor. They are seeing, in terms of percentage, a deeper response in the FOLFIRI plus cetuximab arm. So maybe the picture is more complete when you now take the independent review. There is some more response associated with FOLFIRI plus cetuximab, and there is some longer overall survival. But still there is some doubt why, for instance, the progression-free survival was completely negative. This is a bit conflicting within this study.
It's an interesting, even a transatlantic issue, because I can see that the interpretation of the FIRE-3 and the 84-5 data vary between the continents, actually. Because
what's your perspective on that?
The US intergroups trial was much larger than the FIRE-3 study, had overall survival as endpoint, had a similar design in terms of chemotherapy plus cetuximab or bevacizumab, 1,137 patients, had 70% were FOLFOX, so a smaller percentage, but eventually with 1,100 patients to begin with, pretty large subgroup of patients with FOLFIRI. And the overall survival results were presented last year in a very kind of preliminary fashion, I would say now, without comprehensive RAS analysis, no response data, etc. So we'll see data today where, so number one, the CLGB SWOG study does see an incremental benefit in terms of response for the use of EGF receptor antibody. So that is in line with what you see with the central review in FIRE-3. Still no difference in PFS in all RAS wild type, and no difference in overall survival in all RAS wild type, not even broken down by any FOLFOX or FOLFIRI subgroup. And the numbers of patients at risk at the tail of the curve where the FIRE-3 study separates is about 3 times higher than the FIRE-3. So the US perspective is FIRE-3 was interesting, but the 84-5 study does not confirm the results in overall survival. And I think ours, with the limitation that 84-5 does not have a lot of data yet in terms of duration of therapy, second and third line therapies, which I think really influence long-term survival. What is encouraging, and I think you and I, you mentioned this earlier, agree that patients are kept alive long nowadays. I mean, the all RAS wild-type patients in 84-5 now live way beyond 30 months in median. This is
which is really good news.
Really good news. So,
almost regardless if you start with the anti-VEGF or the anti-EGF.
That's exactly what I think. For us, it creates, as you said earlier, with gastric cancer and pancreas cancer, as clinicians we have options. And my takeaway is good news for patients.
Absolutely. And I don't want to go too deep into this discussion, should we start with this or that, because certainly we have two good options now. Maybe it will be interesting over the next months to go more into detail with the presented data and to see, are there some subgroups who may have a particular benefit. Let us look at those patients with oligometastatic disease, at those patients patients who have a realistic chance to get to secondary surgery, there may be some differences. This could be my perspective at this stage. We have slightly more response chances with a combination of chemotherapy and anti-EGFR treatment. So this may guide us.
In which patient does it really matter?
In which patients does it really matter?
Yeah.
On the other hand, we have some more side effects associated with the anti-EGFR treatment, especially the skin toxicity, basically. So I think we will end up with individual decisions based on the data we have, but there is no general fight. There will not be one way to go, neither in Europe nor in the US, I assume.
I still hope that we will identify, perhaps even on a molecular basis, a patient profile that makes these patients extremely sensitive to EGF receptor antibody therapy, that we could refine this patient population, really benefiting perhaps long term with long delay of tumor progression. On the other hand,
I think that is a very important point that you're mentioning, because we have been talking a lot about biomarkers, and we have a biomarker here, the RAS mutation analysis, but this does not really tell us who will be a very, very good responder. It will exclude patients who are not no candidates for anti-EGFR treatment, but now we should start to define treatments in a positive way and to see, do we have a signal, do we have a signature that has a positive predictive value to choose the one or the other treatment, and we don't have that yet.
And again, coming back to options, I remember years ago when there was almost a religious war between oxaliplatin and irinotecan, and which one, and there were kind of camps, supporting one way or the other. Eventually, we've figured it out. We have developed certain preferences. We know side effect profiles. We know we need to use all these agents anyway. And so I can see that this will also emerge with the biologics right now, with the added benefit that we now hopefully have better tools refining patient population. Yeah. Cool. Yeah, a lot to talk about.
Yes.
Thank you very much, Florian. And
thank you. It was my pleasure.
Thanks for listening to Best of the Day at ESMO 2014. My name is Axel Gothi. Thanks for watching.